My name is Aruna Pradhan. I'm a cardiologist and epidemiologist from the Brigham and Women's Hospital and Harvard Medical School in Boston. And over the course of the next 25 minutes or so, I'm going to address two questions here. Have we reached the limits of lipid-lowering therapy, and what next? My disclosures are shown on this slide. And in terms of topics, we'll discuss whether extending LDL lowering to low and very low levels pushes us to the limit in terms of benefit. We'll also talk about new LDL lowering therapies, in particular triglyceride-rich lipoproteins as a target and a promising new frontier, and also lipid reduction for total cardiovascular events, and that means reducing first and subsequent events, and also encompassing peripheral artery disease, which is a growing problem. And finally, I'd like to talk to you about women and disadvantaged minority groups and whether we are reaching all patients with our current lipid lowering management strategies. So I think we can all fairly agree that statins, ezetimibe, PCSK9 inhibitors are well established and have achieved the evidence threshold in terms of cardiovascular risk reduction. And these agents converge through their mechanisms to increase LDL receptor upregulation and enhance LDL uptake. Now, we also have enough evidence to have expectations of cardiovascular event reduction per millimolar reduction in LDL cholesterol. And that's shown nicely from the curves that are called the Oxford curves from the CTT group, which demonstrate a linear association between LDL reduction on the x-axis and the proportionate reduction in cardiovascular events. And what's plotted here are mainly the statin trials, but also IMPROVE-IT, an ezetimibe trial, and links in a linear fashion a reduction in LDL to a reduction in cardiovascular risk. And we can expect per millimole per liter reduction in LDL about a 20 to 25% reduction in cardiovascular risk. Now, what's shown here also are the results for FOURIER, the efficacy trial with evolocumab, and you can see in the magnified view that this trial, in terms of its risk reduction compared to its LDL reduction, falls below the expectations based upon the Oxford curves. And we have to ask, do these data suggest that PCSK9 inhibition, especially to low levels of LDL, falls below the mark? Is there a diminishing return beyond which LDL reduction yields no additional benefit? So post-hoc analyses have been performed to recalibrate these curves for the duration of treatment, which accommodate the shorter duration of FOURIER follow-up. And you can see here in these curves that if adjusting for the duration of treatment, that the expected benefit is now linked to duration of therapy. However, we have to ask, are there other potential explanations? Is there less benefit of lower on-treatment LDL cholesterol once you get to these very low levels? Is there less benefit in statin-treated patients who have already been on therapy for some period of time? Is there the response variability with PCSK9 inhibitors, do they account for this difference? And then finally, is the lack of anti-inflammatory effects conferred by these agents in some way related to a reduction in cardiovascular risk that might have been expected? So the next slide illustrates this point. If we look at comparison of the cumulative event curves for FOURIER and ODYSSEY outcomes to the two efficacy trials for PCSK9 inhibitors on the left, comparing that for the anti-inflammatory trials that were recently released, CALCUT and LIDOCO-2, I think what's illustrated by these data is that although all agents showed a risk reduction, that the anti-inflammatory effects may emerge earlier than the lipid-lowering effects conferred by PCSK9 inhibition. So we have to ask ourselves, is there something missing by using PCSK9 inhibition, which does not have the additional anti-inflammatory effects, both shown for colchicine, but also for statin therapies in previous studies? So where do we go from here? There are newer LDL-lowering therapeutics that are coming on the market and certainly very exciting. Several agents are shown in this graphic. Bempedoic acid, which is a small molecule targeting the ATP citrate lyase pathway, inclisiran, a small interfering RNA molecule which targets PCSK9, and then evinacumab, fully human antibody that targets the ANGPTL system. Now, all of these agents have had some evidence of efficacy in terms of LDL lowering. These drugs differ in terms of their delivery mechanism, their dosing frequency, and the achieved LDL expectation with initiation of therapy. Bempedoic acid is interesting in that this agent also has some anti-inflammatory effects, as shown by a 25% reduction in C-reactive protein, in addition to the LDL lowering effect. Now, we await pivotal cardiovascular outcomes for both bempedoic acid and inclisiran. Inclisiran in particular has a large LDL lowering, 50 to 60%, and we anticipate these trials will show benefit just as other agents in this area. Now, as we look at alternate targets for lipid-lowering therapy, it's important to understand that this field is emerging, that there are certainly areas that we've explored before, HDL lowering, that have not panned out. In the present, we are looking at aggressive and more aggressive LDL lowering. And then there are emerging targets such as triglyceride-rich lipoproteins, which have some very exciting data. And then in terms of the future therapies, which we won't have time to touch on today, certainly Lp(a) reduction is also a potential avenue for therapy. Now, when we turn to triglycerides, important to note is that when we measure triglyceride levels with a ubiquitous and robust assay, that triglyceride level provides an estimate of TG mass and not triglyceride distribution. And that's important because what's not reflected in that value is the distribution of atherogenic lipoproteins. Shown here is the particle diameter against density, and you can see in black are those lipoproteins with the highest triglyceride concentration, and certainly a single measure of triglycerides does not tell us how many of these particles are circulating in individuals at increased risk. Now, a lot of information has emerged in terms of intravascular remodeling of these particles, how they convert from their phase 1 initially secreted particles, the chylomicrons and VLDL, to downstream particles that are remnants and smaller, potentially able to get into the subendothelial space and promote plaque formation. But do they actually get in? What is the evidence for that? We've come kind of full circle on this issue. This in the left lower panel is a photograph of the initial paper by Dr. Silversmith, who made this observation or hypothesis over 50 years ago, potentially linking triglyceride-rich lipoproteins to atherogenesis. Since that time, we've had increments in terms of basic science data that have shown that these particles do in fact penetrate the arterial endothelium, and this is in a size-dependent manner. But much of these data, I have to say, are somewhat old. I anticipate with the cardiovascular reduction data that I'll show you in a moment, we'll be revisiting the biologic basis for the clinical findings. So what do previously conducted clinical trials show us in terms of strategies to lower triglyceride levels as they pertain to cardiovascular risk reduction? We do have 5 major fibrate trials that have published, 2 niacin trials, and then 1 major icosapent ethyl trial prior to the current data I'll show you from Reduce It. And what we saw in those trials is that if we took the entire cohort of patients not selected for high triglyceride levels, that there were modest, in some cases significant reductions in cardiovascular events. But if you looked at that subgroup of patients who had high triglycerides to begin with, dramatic risk reduction shown on the right-hand side, in some cases 2 to 3 times for the entire cohort, and all of these are statistically significant in these post-hoc subgroup analyses. So with that data in mind, there are 3 major cardiovascular outcome trials that have either reported or ongoing that have enrolled patients with mild to moderate hypertriglyceridemia using 2 different types of agents. Reduce It and Strength have already reported and use high-dose purified omega-3 fatty acids. And Prominent, the last to report, projected to report in 2022, uses a highly selective PPAR alpha agonist, pemafibrate. These are all international trials, all having patients with high cardiovascular risk, all with prior statin use and good LDL control. And then what you can see at the bottom in terms of their triglyceride lowering, at least 20% or so for the fish oil trials, and then 40% reduction for pemafibrate. So let's break these down in a little bit more detail. Of course, Reduce It was published in 2019, showed dramatic risk reductions in this well-conducted study, shown here, 25% risk reduction over a 5-year period of follow-up, an absolute risk reduction of about 5%. In the primary endpoint of cardiovascular disease death, MI, stroke, coronary revascularization, or unstable angina. What was surprising from these data, however, were that triglycerides didn't seem to matter. Achieving a low triglyceride level, whether for the primary endpoint on the left or the secondary hard cardiovascular endpoint on the right, did not seem to matter in terms of the benefit derived from the drug. So the question became, is it triglycerides or is it something else that these agents are modulating to confer cardiovascular benefit? And if we look back at the data, this really should not come as much surprise. The cardiovascular benefit from the 2 fibrate trials that did show some statistically significant risk reductions, VA HIT on the left on the slide and Helsinki Heart Study on the right, these trials also failed to show a linkage with triglyceride reduction in terms of the risk reduction achieved. And it may be an issue having to do with the variability of triglyceride levels. There is both diurnal variability and day-to-day biologic variability shown in the chart to the left. You can see much higher biologic variability for triglycerides than for LDL cholesterol, for instance. And then on the right-hand side, although fibrates and therapies at lower triglyceride levels do reduce the postprandial surge in levels, there's still significant variability depending on the time of sampling after a meal. So it's possible that a single triglyceride level may misclassify patients in terms of their residual risk. Now, what's also extremely interesting and somewhat perplexing in this area is that the strength trial, shown on the right, the event curves there, showed no significant cardiovascular benefit. Those curves are right on top of each other, and this was with a mixed purified preparation of EPA and DHA, and the question becomes, was it the addition of DHA that may have neutralized the benefit of EPA? It really remains to be known what would have driven such divergent results from these 2 trials. So let's now turn to the last of these triglyceride lowering trials, Prominent, projected to end in 2022, fully enrolled, and using a selective PPAR alpha agonist, pemafibrate, which has about a 40% reduction in triglyceride levels. Now we know from phase 2 data that the drug is safe. We also know that in addition to lowering triglycerides in the top left box, that this agent has significant benefits in terms of reducing ApoC3, TRL remnants, small dense LDL, and other parameters shown here, ApoB48 as well. Now, the Prominent trial is enrolling 10,000 participants with type 2 diabetes, so specifically in that patient population, with a similar primary endpoint. It's event-driven and will be conducted over a 5-year period with anticipated end of follow-up in 2022. Now, there are other triglyceride-lowering agents in development, and those are shown here. These target both TRL production as well as TRL clearance. Some phase 2 studies have been completed, and we anticipate that these will move on to phase 3 studies and provide us some data with regard to cardiovascular risk reduction. Now, what about total cardiovascular risk reduction? We've been seeing an increasing number of published data that report on both first and subsequent events because, of course, as clinicians, we want to know not only whether long-term use of these agents prevents the first event, but whether adherence and long-term therapy reduces total events. These are data from the Reduce trial, which I think exemplifies the benefit that may be achieved by looking at this type of data analysis. On the left-hand side for placebo and for the right-hand side for icosapent ethyl. The first event, that's the hazard ratio presented previously, 25% reduction. But if you start looking at second, third, fourth events, even increased risk reduction, about a 30% risk reduction overall, and the arrow indicates that we're talking about a large number of events, almost triple the number of events if you had limited yourself to the first events analysis. Now, with regard to peripheral artery disease, another area that has been understudied and perhaps we should be pushing the limits, on the left-hand side are the prevalence of peripheral artery disease across the globe in relationship to other vascular disorders. And you can see that the bar for peripheral artery disease almost approaches 200 million. And in fact, this is probably one of the least recognized cardiovascular disorders. There is certainly a gap in terms of our evidence base for therapies that reduce PAD outcomes, and it's illustrated on the right-hand side if you look at the over 25 cardiovascular outcome trials of anti-diabetic agents, and diabetes, of course, is the most important driver of PAD. Less than 1/3 have evaluated PAD outcomes. And there is benefit potentially to be derived. The data from Field are shown here looking at phenofibrate and did demonstrate a reduction in amputation when combined minor and major amputations were evaluated. That's on the left-hand side. New or worsening PAD is a pre-specified adjudicated outcome in prominence, so we'll have those data to evaluate in that trial as well. With regard to women and disadvantaged minority groups, it's important to know that sex and race are both social and biologic constructs. And by that I mean that there are social determinants of health that are indicated here: gender, culture, income status, employment, working conditions, and these impact cardiovascular health and are related to both sex and race. And then there are also potential biologic determinants of cardiovascular health. And these have been fairly well fleshed out for women with emerging data looking at race-specific differences. But you can see that there are differences in body composition, glucose homeostasis, and lipid profiles that clearly differentiate women and men with regard to these vascular risk factors. As a result, underrepresentation of women and minorities in our cardiovascular outcomes trials limits our ability and our mission to achieve global cardiovascular risk reduction. Now, these data were published earlier this year, aggregate data from over 700 clinical trials, looking at the proportion of women enrolled in these trials as compared to the prevalence of a disease among women in the population. I think what you can see on the left-hand side is irrespective of the disease type, panel A, intervention type, whether it's lifestyle, drug, or device, region, global, Europe, or America, and then the size of the trial, that the proportion of women relative to the prevalence of a disease is quite low. A value less than 0.8 is depicted by the red lines, and that suggests underrepresentation, with no trial really except for those evaluating pulmonary hypertension having overrepresentation of women. And I think if we examine these populations more carefully, there's a lot to be learned. Shown here are the racial differences observed within a number of cardiovascular risk markers when we compare Black women on the left to non-Black women, and Black men to non-Black men on the right, those markers or those indicators to the right of the line of unity suggest that there are higher levels in women of Black or African American descent compared to non-Black women, both for lipoprotein A at the extreme, but also some differences shown here for other lipid parameters, including triglycerides, which tend to be much lower, both for Black men on the left, and then also significant differences for Black men on the right. Okay, we've gone through a lot of information here. I'd like to end by just acknowledging collaborations, mentors that have helped with this work, in particular Paul Ridker, Peter Libby, Mark Krieger, as well as associates that I've collaborated closely with throughout my career.